Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Picture the workflow. You're sitting at the workstation, powering through a massive stack of thoracic CTs.
Right, the usual afternoon grind.
Exactly. Maybe it's a trauma rule out or, a routine PE study. You're scrolling through the lung windows, everything looks clear, and then bam, you hit a nodule.
And you pause.
You pause, you toggle up and down, and you realize pretty quickly, that is definitely not a granuloma.
No, because it has a feeding artery.
Right. And a draining vein. You've just stumbled onto a pulmonary arteriovenous malformation, a PAVM.
The classic incidentaloma. And for the interventional radiologist listening right now, finding a PAVM is, it's one of those specific moments where an incidental finding carries this weight of responsibility.
Today we're unpacking a topic that is highly relevant for your practice, because what you do next with that incidental finding, and specifically how you treat it, it literally determines whether that patient lives a normal life or, ends up with a devastating neurological injury at age 40.
Yeah, and that tension is exactly what we're exploring today, because how we treat has changed dramatically.
Completely. I mean, if you look at the training dogma from 10 or honestly even 5 years ago, the approach was basically proximal embolization.
Right, the old school method.
Find the feeder, coil it, shut down the flow, and move on.
And if you take one thing away from our deep dive today, it's that proximal embolization is essentially obsolete.
It's out.
Totally out. We're seeing a complete paradigm shift in the literature. We're moving from this idea of blocking the pipe to what Dr. Lynne Martin from Stanford Interventional Radiology calls packing the bucket. We will cover everything from the baseline genetic to the very specific catheter selections.
Our mission today is to equip you with the latest data. We're going to cover the epidemiology, we're going to bust the myth of the 3mm feeding artery, and we'll get into the very specific technical guidelines for packing the nidus so it doesn't come back.
Because the core technical message here is, if you jail the nidus with the proximal coil, you aren't just failing to cure the patient. You might actually be making the lesion impossible to treat in the future.
Right. And we'll get deep into the pathophysiology of why that recurrence happens. But before we get the catheters out and start talking gear, we need to talk about the patient sitting in front of you in clinic.
Absolutely. Because that incidental finding on the CT, it's almost never just a localized problem.
Right. Let's hit the epidemiology. You see one PAVM, just one. Is it a one-off?
I mean, if it is truly a solitary lesion, then yes, you're looking at sporadic disease. That accounts for maybe 10 and 20% of cases.
Okay, but what if there's more than one?
The second you see multiple lesions, the sensitivity for hereditary hemorrhagic telangiectasia, or HHT, shoots up to over 90%.
Over 90%. So finding multiple PAVMs is effectively a genetic diagnosis of HHT until proven otherwise.
For all intents and purposes, yes, you have to treat it that way. And for the IR, knowing the patient's genotype isn't just, academic trivia. It completely changes your screening algorithm.
Let's break that down, because you've got HHT type 1, which is the ENG mutation, and then HHT type 2, the ACVR-L1 mutation. How do those distinct genotypes actually change your clinical workup?
So HHT type 1 is the phenotype that should make you really nervous about the lungs and the brain. These patients have a significantly higher prevalence of PAVMs. We're talking up to 75% of them have lung involvement.
Wow.
And there's a really strong correlation with cerebral AVMs too. So if I have a type 1 patient sitting in my clinic, I am heavily scrutinizing that screening brain MRI.
Okay, whereas type 2?
Type 2 is generally a bit lighter on the pulmonary and cerebral manifestations, but it's much heavier on hepatic AVMs and pulmonary hypertension.
Oh, okay.
So for those type 2 patients, you're looking closely at their liver function, their cardiac output, and right heart pressures. It's a totally different flavor of systemic risk.
Now, practically speaking, in the clinic, we use the Curacao criteria. It's the standard checklist. I want to briefly touch on it because Dr. Martin emphasizes it as this really quick, effective clinical heuristic.
Yeah, it's an easy 4-point check that every IR should have memorized. First, spontaneous recurrent epistaxis, nosebleed. Second, telangiectasias in typical distributions. So you're looking at the lips, the fingers, the oral mucosa. Third is visceral lesions, which obviously is why they are seeing you for the PAVM.
And the fourth is family history.
Exactly. And if they meet 3 out of those 4 criteria, that is a definite clinical diagnosis of HHT. It really helps you cut through the noise when you're doing a consult.
Okay, so let's pivot to the actual stakes here. Why are we so aggressive about treating these? As I feel like there's a lingering mindset in some parts of the medical community, maybe among some referring docs, that if the patient isn't hypoxic, the PAVM is stable.
Yeah, and stable is a very dangerous word to use here. The primary indication for intervention is almost never hypoxemia.
Right.
It's the prevention of paradoxical embolism. Think about it. The lung is the body's venous filter. A PAVM is a breach in that filter.
It's a bypass track.
Exactly. It allows thrombus, air, bacteria, whatever is in the venous system to completely bypass the capillary bed and head straight for the systemic circulation.
Which obviously puts the brain directly in the firing line.
We know the stroke risk is somewhere between 10 and 32% for these patients. It is incredibly high. But the stat from Dr. Martin's data that I actually found most disturbing was regarding silent brain infarctions, or SBIs.
Yeah, this is that concept of cumulative subclinical damage.
Precisely. We aren't just talking about the catastrophic hemiplegic stroke that brings them to the ER. We're talking about small, completely silent ischemic events. The prevalence of SBI in PAVM patients is 40 to 50%.
Almost half of these patients have ischemic changes on their MRI.
Yes, and it's often occurring much, much earlier in life than you'd expect for vascular dementia or ischemic changes. So you end up with a 30-year-old patient who have the cognitive reserve of a much older person.
Just because their brain has been taking these tiny micro hits for years and years.
Exactly. And then on top of the ischemic risk, there's the infection risk, brain abscess.
Right. The literature quotes a lifetime risk of 5 to 9% for brain abscess in untreated patients.
That's just roughly 1,000 times the risk of the general population. And we have to be really specific about the mechanism here because it directly changes how you counsel the patient before they leave your clinic.
The Odontogenic Connection. This blew my mind a little bit.
Right. It's intimately linked to dental hygiene and dental procedures. The mouth is just full of anaerobic bacteria.
Sure.
In a healthy person, a routine dental cleaning causes transient bacteremia. The bacteria hit the pulmonary capillaries, they get filtered out and destroyed by macrophages, and it's over. No big deal.
But in a PAVM patient?
In a PAVM patient, that shower of anaerobes bypasses the lung entirely. It shoots right through the right to left shunt, goes up the carotids, and seeds the gray-white junction in the brain.
So antibiotic prophylaxis is mandatory for these patients?
Absolutely mandatory. Lifetime prophylaxis for any dental procedures. It is such a low-cost intervention that prevents an incredibly high morbidity complication. You have to tell them that.
Which brings us to what we called the size myth in our prep. I clearly remember the 3-millimeter rule. If the feeding artery is less than 3 millimeters, you leave it alone. It's safe. But Dr. Martin suggests that rule is just entirely dead.
It should be dead. That 3-millimeter threshold was based on very old data, and frankly, it was based on the limitations of older catheter technology.
We just couldn't reach them safely.
Right. And the logic back then was that small vessels don't pass big enough clots to matter. But the physiology just doesn't support that at all. A 2-millimeter vessel is still a direct conduit for bacteria or air.
So the lack of a filter is basically binary. It's either filtering or it's not.
Correct. The current reality, supported by recent guidelines, is that any measurable PAVM that can be catheterized safely should be considered for treatment. We are routinely treating 2-millimeter feeders now because we know they absolutely still carry that stroke and abscess risk.
Before we get into the how of the procedure, I want to flag the pregnancy aspect, because pregnancy seems like the ultimate physiological stress test for this specific pathology.
It really is. Normal pregnancy involves a 40 to 50% expansion in maternal plasma volume and cardiac output.
That is a massive hemodynamic load on the right heart and the pulmonary circuit.
Exactly. And if you have a PAVM, that increased flow, combined with the hormonal changes that naturally induce vasodilation, it can cause rapid, unpredictable growth of the malformation.
And ultimately rupture.
The risk of spontaneous rupture peaks in the second and third trimesters. And if a PAVM ruptures into the pleural space or the airway during pregnancy, the maternal and fetal mortality rate is significant.
So what's the clinical guidance there?
It's aggressive. You optimize these patients before conception, if at all possible. Screen them, treat them. But if they show up to your clinic and they are already pregnant, you still treat them.
When?
Typically in the second trimester. Because the radiation and procedural risk of the embolization is far lower than the risk of a spontaneous hemothorax in the third trimester.
Okay, let's get into the angio suite. Let's talk anatomy first. We generally divide these lesions into simple and complex.
Right. Simple PAVMs make up the vast majority, about 80 to 90%. You have a single segmental feeding artery, an aneurysmal sac or nidus, and a single draining vein.
They seem conceptually straightforward, though I know getting the catheter there isn't always easy.
Exactly. And then you have the complex ones, which are the other 10 to 20%.
Multiple feeders.
Multiple feeders, often coming from completely different segments or even different lobes, feeding into septated, irregular sacs. Those are technically very demanding.
But there's a third category that Dr. Martin emphasizes. And this is where I think a huge amount of procedural recurrence actually happens. Systemic supply.
Yes, the hidden threat.
Yeah.
Systemic supply is the silent killer of procedural success in these cases. We focus so much on the pulmonary artery, right, because it's a low-pressure system. I mean, pulmonary pressures are, 15 to 20 millimeters of mercury?
Right.
But you can have collateral feeders coming from the bronchial arteries or the internal mammary or the intercostals.
And those are hitting the sac at systemic aortic pressures.
Exactly. High pressure. I mean, arterial pressure of 90. If one of those systemic feeders ruptures, it is not a slow ooze. It is massive, immediate, life-threatening hemoptysis. But the more insidious thing for the IR is that these systemic vessels frequently cause recurrence. You treat the pulmonary feeder perfectly, you feel great about the case, but the sac stays alive because it's getting backfilled by a tiny bronchial branch you didn't even see.
Because you didn't inject the aorta, you only did a pulmonary run.
If you are only doing a pulmonary angiogram, you will completely miss the systemic supply. So if you have a patient who has been treated but still has symptoms, or you get their follow-up CT and the sac is still opacifying despite a massive coil pack, you have to go hunting.
You have to pull the pigtail down and look for that systemic feeder.
Do an aortogram. Do selective intercostal or bronchial runs.
Let's talk about the core treatment philosophy then. The shift from proximal occlusion to nidus occlusion. Why did that old block the pipe way fail so often? The data shows recanalization rates of 40 to 60% with proximal coiling. That's honestly abysmal.
It is, and it's basically human physiology fighting back against our intervention. When you place a coil, approximately, let's say, a centimeter or two upstream from the sac in the feeding artery, you drop the pressure distally.
Right, but you haven't actually destroyed the nidus itself.
Exactly. That nidus is still sitting there. And now you've created a low-pressure, highly ischemic environment downstream of your coil. That ischemia triggers a massive release of VEGF and other vasoactive endothelial factors.
The lung tissue interprets it as an injury that needs healing and blood flow.
So it recruits collaterals. Tiny microscopic vessels from the vasa vasorum or from adjacent pulmonary segments start to dilate. They bypass your coil plug, and they find a way right back into the sac.
And now you have what the literature calls a jailed nidus.
This is a nightmare scenario for an IR. You have a huge proximal coil blocking the only main navigable road into the AVM. But the AVM is still alive, it's still growing, and now it's being fed by a network of tiny, tortuous vessels that are way too small to ever catheterize.
You can no longer access the sac to pack it. You've essentially burned the bridge.
You've burned the bridge, and the patient is still at risk for stroke.
So the new gold standard, what we're advocating for today, is nidus embolization, or venous sac embolization.
The goal is complete, dense, mechanical occlusion of the sac itself. You want to fill that aneurysm so completely with metal that there is physically no space left for blood to pool or flow.
Dr. Martin cites a really compelling study of over 200 PAVMs, where this specific technique, packing the sac, had a success rate of 94 to 100%, with 0% reperfusion in controlled cohorts.
It's night and day compared to proximal coiling.
So let's talk about the gear. How do you actually achieve this dense pack? What are we packing the bucket with?
You need incredibly soft, very long detachable coils. The term Dr. Martin uses, which I love, is liquid metal. You want coils that are highly compliant, so they can form to the weird irregular shapes of the nidus, but without exerting too much outward radial force. Because if the coil is too stiff, you'll rupture the sac right there on the table.
Specifically, the presentation mentions the Penumbra LP system.
Yeah, the Penumbra LP is a real workhorse for this. We are talking about using 60-centimeter length coils. You want massive volume. You get your microcatheter, and you usually need a really soft 2.0 French system to get that distal right into the belly of the sac, and you just start feeding coil after coil after coil.
You're essentially casting the aneurysm in metal.
Exactly. You pack it until the coil mass literally starts to herniate backwards into the feeding artery. You want a really dense pack. This isn't about throwing a few fibers in to induce thrombosis. It's about pure physical space occupation.
What about vascular plugs, like the Amplatzer MVP or the Lobo? They seem a lot faster than deploying 20 feet of microcoil.
They're definitely faster, and they're excellent devices, but they have a very specific contraindication here. You cannot put a vascular plug inside the nidus itself.
Because the nidus is amorphous, right?
Right. A plug has a fixed engineered shape, usually a cylinder or a disc.
Mm.
If you deploy a cylindrical plug into a round or floppy, irregular sac, it will not anchor properly. The venous flow will eventually just push it right through the draining vein and straight into the left atrium.
And then you're calling cardiac surgery, or you're fishing your device out of the patient's descending aorta.
A totally preventable disaster.
Ah,
So plugs are strictly for the feeder vessel.
okay.
Yes, if you have a simple PAVM with a nice straight uniform feeding vessel, you can absolutely place a plug. But the strict rule of thumb is that the plug needs to be placed within 1 centimeter of the nidus.
Because if you deploy it too proximally,
You risk that exact same ischemic collateral recruitment we just talked about. You jail the nidus.
so for a complex sac or a lesion with a really short neck, coils are always king.
Coils give you the ultimate control. You can basically paint the inside of the sac.
Let's discuss the technical challenge of visualization during all this. We are working in 2 dimensions on the fluoro screen, but the lung is this incredibly complex 3D structure with hundreds of overlapping vessels.
This is where the sheer technical skill of the IR really comes into play. Subselection is just plain difficult. You are battling cardiac motion. You are battling respiratory motion. You need to be very comfortable working in steep oblique views to visually separate your target feeder from the background pulmonary tree.
And breath holds must be crucial.
If your patient is under moderate sedation, but they're breathing freely or erratically, your roadmaps are completely useless.
It's just a blurry mess.
You need a patient who can reliably follow breath hold commands, or honestly, if you're under general anesthesia, you need to coordinate tightly with your anesthesiologist to induce temporary apnea during your runs and your deployments.
Okay, so say we've successfully packed the sac, beautiful result on the table. What does the follow-up look like? Obviously, we want to see the sac completely disappear on the follow-up CT.
Right. Ideally, the sac just involutes over time. It becomes a dense little scar around the coils. But we also look really closely at the draining vein on that scan. If the draining vein collapses down to nothing, that is a fantastic sign that you've totally killed the inflow.
There is some really interesting data from Woodward et al. Regarding persistence. They found that even if flow eventually returns to the sac, the outcome might not be a total failure.
This is the filter effect concept, and it's fascinating. They found that in patients where the PAVM reperfused, meaning contrast, was visibly getting through the coil pack on follow-up, there were 0 strokes or brain abscesses during that persistence period.
Because the dense coil mass itself was acting as a mechanical filter.
Exactly. Even though blood was flowing, the coils were physically trapping the microclots and the bacteria. Now, I want to be clear, that doesn't mean we just accept reperfusion as a clinical success.
Right, you still have to deal with it.
But it does mean the patient is relatively neurologically protected while you sit down and plan the reintervention. You have time.
So if we do see recurrence on the CT, what is the actual clinical trigger to go back in and retreat?
Well, symptomatic recurrence is an automatic retreat. If they start having TIAs or hypoxemia again, you go. If the nidus is measurably growing on the scans, you treat. Or if the shunt grade on a follow-up bubble echo remains stubbornly high, like a grade 2 or 3, you probably need to go back in.
And when you go back, that is exactly when you start hunting for those systemic feeders.
You first look closely to see if you just miss a secondary pulmonary feeder, but then you immediately interrogate the bronchial arteries and the internal mammary arteries. Because the recurrence is rarely the coil failing mechanically. It's usually biology just finding a clever way around your coils.
You know, this whole shift in technique from proximal coiling to nidus packing, it feels like it mirrors a much broader shift in the field of interventional radiology towards more durable, definitive, biologically aware treatments.
It absolutely does. We are really moving away from being, just catheter plumbers who simply stop a leak.
Yeah.
We have to be physicians who deeply understand the hemodynamics and the biological response of the endothelium to our interventions.
Yeah.
Don't gel the nidus isn't just some catchy phrase for a slide deck. It's a fundamental recognition that if we don't treat the disease at its actual source, the disease will eventually outsmart us. It is the only reliable way to ensure these patients are actually protected from the stroke or the abscess that is constantly hanging over their heads.
So for the IR listening who might see one of these on their schedule next week, remember to check the Curacao criteria, screen them for HHT, think about the systemic supply, and when you finally get in there, tack the bucket.
Pack the bucket, fill it with liquid metal, and keep looking until you are absolutely sure there isn't some tiny bronchial artery trying to ruin your work.
It does leave you with one provocative thought, though. What happens to the local microvasculature long term, even after we pack the bucket perfectly? Does that segment of the lung ever truly normalize its filtering capacity? Or is the architecture permanently altered? Something to mull over as we wait for the next 10 years of data. That's all. Thanks for listening.
Hi all, Lynne Martin from Stanford University. Thanks for listening to the podcast. You'll have to excuse my groggy voice. I have a little bit of a cold in recording this, but I think the podcast really brings to light a lot of the nuances of treating pulmonary AVMs. I'd like to mention that if you think your patient has HHT, that they really be seen at an HHT center of excellence, as they frequently need long-term surveillance and management of other things going on. I'd also like to clarify that when I say treatment of the nidus, what I really mean is getting that microcatheter all the way across that nidus to that aneurysmal draining sac. And then basically coiling from that aneurysmal draining sac across that connection to the distal feeding artery. And that really gets rid of the AVM in its entirety and gets rid of basically any reason for persistence and has very high rates of technical success. Treatment of a plug in the distal feeding artery can also have very high rates of success. And I think that's frequently because a lot of the pulmonary AVMs are type 1 or simple pulmonary AVMs, and therefore taking out that feeding artery can be appropriate and can result in good treatment success as well. But in my opinion, if you can get within 1 centimeter of that AVM, you might as well get to the nidus and then treat the entirety of the AVM. And I use really long packing coils, depending on the size of the AVM, anywhere from 60 centimeter to 30 centimeter packing coils, so that I really am coiling across the entirety of that AVM. These patients should also be getting, antibiotics for any procedure that could cause transient bacteremia. In terms of the pregnancy literature, that is in regards to patients who have pulmonary AVMs with feeding arteries over 4 millimeters, and they can show very high rates of rupture, up to 40 to 60%. But in patients who have feeding arteries less than 4 millimeters and very small AVMs, then multidisciplinary discussion and potentially surveillance may be appropriate in those patients, but very tricky situations to deal with. Also be mindful in your HHT patients that they can have AVMs elsewhere in the body. And during treatment of our pulmonary AVMs, we anticoagulate. And so particularly with those who have brain AVMs, I like to have those managed first and treated first before I bring those patients in for pulmonary AVM treatment to reduce that risk of hemorrhage from AVMs elsewhere in the body. The other tip I'd like to mention is that for my complex AVMs or patients with multiple AVMs, I really like to use jet ventilation. And jet ventilation gets rid of all respiratory motion and can make navigation of the lungs and the use of road maps much, much easier. And so that's been key for some of my more complex patients as well.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.